Hi, this is Stephen Richeimer, and today we're going to discuss muscle relaxants. So, first, let's get a little background. How does our motor system, which controls our muscles, work? Okay, so in the upper left-hand side of the slide is a quick schematic of the brain, the motor cortex sending fibers down to the brain stem and on into the spinal cord. The spinal cord ends at L1, L2. Somewhere between the brain stem for the cranial nerves and the end of the spinal cord, nerve roots come out which contain both sensory and motor components. So again, next to my little image or schematic of the brain, right next to it you see a cross section of the spinal cord. And the top part of that image is the back of the spinal cord, and that is the dorsal part, and sensory nerves enter there. But the ventral part, the front, the anterior part of the spinal cord, is where the motor neurons synapse that come down from the brain, they synapse there in the ventral horn and then leave the spinal cord and head out to muscle. So from the brain down to that synapse in the ventral horn of the spinal cord, those neurons are what we call upper motor neurons. The synapse connects to a lower motor neuron, and those are the nerve fibers that leave the spinal cord in the ventral root and head out to the muscles. And so you can see, as we're kind of moving to the right side of the screen here, you can see an image of two motor neurons. One's in purple, one's in red, and they each give rise to branches, and those branches connect with the muscle fibers so that each motor neuron will innervate multiple muscle fibers. And the muscle fibers that are controlled by a single motor neuron are called a motor unit. Now, if we go to the very right side of the screen, there's a photomicrograph. This is a microscopic image blown up 330 times so that you can see these motor fibers and the terminals of the neurons as they connect with these motor fibers. And where they connect, that's another synapse, but it's a specialized synapse called the neuromuscular junction, nerve-muscular junction. And like other synapses, the first part of the synapse, in this case the nerve, is releasing chemicals across that synapse that now bind to the muscle side of the synapse. And the main chemical released here is acetylcholine. So acetylcholine is released from the nerve terminals and binds to what are called nicotinic cholinergic receptors on the muscle fiber. Now, this junction is where the botulinum toxin, most well known by one of its trade names, Botox, the botulinum toxin binds to this in this junction, preventing the release of acetylcholine. And that means that junction won't work anymore. And so what what botulinum toxin does is actually paralyze a bunch of motor units because they can't get the signal, the acetylcholine signal, to contract. So without that signal, because it's blocked by the botulinum toxin, those fibers won't contract and they are essentially paralyzed. Okay, so when we're thinking about muscle relaxants, we should think a little bit about what kinds of problems are we addressing. And there's really two different classes of issues. One is spasticity, and the other is spasms. So a patient with spasticity may have some element of spasms, but true spasticity has really got some clear-cut defining characteristics. So it is defined by the fact that when you move the limb or the muscle rapidly, the muscle responds by an increase in tone. This is different than what we see with spasms. Spasms are involuntary muscle contractions. That's different than an increase in tone, which is dependent on the speed that the muscle is moved. So we often look at this when we examine patients for spasticity. We will move a limb quickly. We'll grab the limb and we'll move it quickly, and we'll feel a cog-wheeling rigidity, a boom, 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 boom type of rigidity, which is the hallmark sign of spasticity. What causes spasticity? A problem in the upper motor neurons. So somewhere between the brain and the end of the spinal cord, that's where the problem lies. And there's lots of different things that can cause this. If we go a couple of lines down, cerebral palsy, multiple sclerosis, stroke, spinal cord injury, brain injuries. Those are the types of things that cause true spasticity. So back up to my etiology line here. If you look on the spasm side, it is a more peripheral, it's not an upper motor neuron condition. It is peripheral muscle or nerve irritation or injury. So in response to some source of irritation in the muscles or in the nerves, typically the lower motor neurons, or the sensory nerves even, something's irritating the sensory nerves, the muscle reacts by involuntary contractions called spasms. How does this look under the symptom row here? So these involuntary spasms look like jerks, twitches, or cramps. It's different than the patient with upper motor neuron spasticity. They are stiff, there's constant high level of tone in the muscle, and they are hyperreflexic. So if you tap on the arm, for instance, at the biceps tendon to get a reflex here, a normal person will give you a little twitch. The spastic patient will go boom. You better not have your face in the way, you'll get hit. So they're hyperreflexic and they have hypertonicity. We went over the causes of true spasticity. What kinds of things typically cause spasms? So might be spinal stenosis, herniated disc, myofascial pain or injuries, musculoskeletal injuries, even poor mechanics, poor posture, poor gait mechanics can be a source of irritation that might trigger spasms, cramps, etc. There's a lot of overlap on the medications that would be used for these conditions. For spasticity, we might use botulinum toxin, which, as I mentioned, will actually cause paralysis of the muscle. Not forever. It typically wears off over a matter of months, 3, 4, 5 months. Baclofen is used. We'll talk more about baclofen a little bit later. Dantrolene, which I'm not really going to talk about more today. That's really specific only to use in spasticity, not for spasms. or myofascial pain. Diazepam, which is known as Valium. Tizanidine, known as Xanaflex. All of these can be used for spasticity. Baclofen, tizanidine can also be used for spasms. Cyclobenzaprine, which is Flexeril. Well, I'll go over all these names in a little bit. Methocarbamol, carisoprodol, and metazoline are all options. So you've had a chance to answer one of the quiz questions. Let's take a look at this case from the quiz a little bit more. A 41-year-old male presents with rapid onset of mid and low back pain. Some pain radiates into both legs. Examination reveals hyperreflexia at the knees and stiffness at the knees, especially with rapid extension maneuvers. Hyperreflexia, velocity-dependent increase in tone. This is true spasticity. This means what? Is the problem an upper or a lower motor neuron problem? As you see here, hyperreflexia equals spasticity equals upper motor neuron. Velocity-dependent tone is, again, a sign of spasticity, and that's an upper motor neuron condition. Upper motor neurons end with the end of the spinal cord. Okay, once a nerve leaves the spinal cord, it's not an upper motor neuron, that's a lower motor neuron. The spinal cord ends at L1, L2. So if we are dealing with an upper motor neuron problem, we are dealing with a problem that is above L1 or L2. An L4-5 herniated disc cannot cause true spasticity. Why not? Because if it herniates into the spinal canal, there's no spinal cord down there. The spinal cord ended up at L1, L2. It's at L4-5 when a disc herniates and it's pressing on nerve tissue, it's pressing on nerve roots that left the spinal cord several levels higher. Nerve roots are lower motor neurons. Lower motor neurons will not create spasticity. So you might see weakness if it's a lower motor neuron condition like an L4-5 severe disc herniation. You might see weakness, you might see loss of reflexes. You will not see hyperreflexia, velocity-dependent tone increased as a result of any problem below L1, L2. Okay, let's take a look at a lot of the different kinds of conditions that frequently get prescribed muscle relaxants. So fibromyalgia is a pain condition, a painful state, typically widespread throughout the body, that the patient feels and describes in terms of muscle pain. And in fact, when their muscles are palpated, they are sensitive, and pressure on the muscle will typically cause pain in multiple spots throughout their body. That is kind of the hallmark of fibromyalgia. But the research is indicating that fibromyalgia is really a neurological problem. It is a neuropathic condition. It's a disorder of sensory processing in the spinal cord and brain. It is not a problem in the muscles themselves. So aiming treatment at the muscles themselves is not likely to provide any long-term degree of relief. So therefore, we probably wouldn't use muscle relaxants for fibromyalgia. Now, I can't tell you this as an absolute rule, because some of the muscle relaxants may affect nervous system processing of pain signals. So maybe they do have some benefit in some cases. Baclofen and tizanidine may have some effect on neuropathic pain, and therefore there may be some benefit. But it's not really because they're causing relaxation of muscle. What about the diagnosis of tension headaches? So we think of them, because they're called tension headaches, we think of them as a problem of muscle tension. And in fact, 70% of patients with tension headache exhibit muscle tightness and tenderness, with the percentage being higher in those individuals who just have episodes of headaches rather than more chronic, constant types of headaches. So there seems to be kind of a spectrum of patients who have occasional episodes of headache where muscle tension may in fact play a bigger role. And as these headaches become more chronic and more constant, we're getting more and more neuropathic mechanisms in play. And the muscles themselves are probably becoming less and less important. So there's a mix of what we might call peripheral and central mechanisms. Peripheral being more the muscles, and central being more the central nervous system, that contribute to tension headaches. And therefore, depending on each individual's mix, where they are on that spectrum from peripheral to central, we will see a different response to different medicines. Medicines that are aimed at muscle relaxation may be reasonably effective for a patient who has just occasional headaches with a lot of muscle tension associated, whereas that same medicine may be completely ineffective for excuse me. That same medication may be completely ineffective for the patient who has chronic daily headaches or regular migraines. Now, there may actually be a process or an evolution over time where a headache evolves from being peripheral to being more central. And it would be great if we could intervene earlier in these patients and maybe prevent more that process of more central mechanisms coming into play. How about for low back pain? Again, this is an area where lots of patients get treated with muscle relaxants. Look at my last line there. In primary care, 35% of patients with low back pain are prescribed muscle relaxants. Okay, let's go back at the top. Low back pain often is associated with muscle pathology, particularly in the large muscles that maintain our posture, which are in the paraspinal along the spine and in the abdomen, the abdominal wall muscles. We see studies that have confirmed that there is increased muscle activity in these paraspinal muscles in patients with low back pain. Physical therapy programs that work on lumbar stabilization and conditioning the spinal musculature, these reduce pain. We see that there are abnormalities in muscle tension. There may be sprains, tears, weakness, spasms, all present in many patients who have low back pain. What's not so clear is what is the cause and what is the effect. Are muscle problems the cause, the primary issue driving many of these low back pain patients? Or are they having another source of low back pain, which now alters how they use their muscles, their posture, and now they start getting into trouble because they're altering their mechanics? There is a study that looked at over 2,000 patients with low back pain. 20% of those had myofascial pain. So that means a huge chunk of low back pain seems to be driven by muscle problems rather than disc herniations or nerve root compressions or other things like that. So again, it's not 100% clear why these 20% have myofascial pain. Is there some underlying trigger, or is this the primary problem that is triggering the condition for the patient? What about temporomandibular disorder? So first of all, recognize diagnostically this term is nonspecific, and there are different schemes for how to classify and break down the diagnosis of temporomandibular disorder. And you're going to hear a lot more about that from our dental colleagues. But for now, I'm just going to break it down to arthrogenic and myogenic. Arthrogenic pathology basically is stemming from the temporomandibular joint. And myogenic pain is stemming from the masticatory or chewing muscles. In epidemiologic studies, the myogenic form is more common. And we do see in studies where we look at electrically in EMG studies, we do see increased tone in these muscles in patients who have temporomandibular pain disorders. We can provide biofeedback treatment, which can make a significant difference. It's also interesting to know that it's the small muscles, such as these muscles around our jaw, that are more prone to developing hyperalgesia, becoming hypersensitive to pain signals, than the larger muscles of our body. So for many patients, muscle is in fact a part of the problem, or the major part of the problem. I can't say it's been shown that the muscle relaxants help these patients, but at least we're trying to target the right thing. What about myofascial pain syndromes? So in myofascial pain syndromes, we're talking about patients that on examination reveal trigger points. A trigger point is a hypersensitive area within the muscle or the surrounding tissue. And that area is typically painful. There may be spasm. You may actually feel when you examine the patient that there is contraction of that muscle. There may be stiffness and tenderness there. The range of motion of that muscle is often reduced if you're able to examine that issue. And there may be weakness associated. The interesting thing is in studies, when we have examiners try to map out trigger points in patients, there's not a whole lot of inter-rater reliability in identifying trigger points. Why do trigger points happen? So there's a lot of different theories out there. Some say there's some underlying condition causing hyperactivity of the muscle spindle, which regulates the tension in the muscle. There may be end plate hyperactivity. There may be, again, involving the muscle. There may be a focal dystonia, abnormality in the muscle that's probably neurologically driven. And there may be psychological issues that are driving increased muscle tension, and over prolonged times those can drive trigger points. Each of these theories is supported by some literature, yet they are often contradictory and refuting each other. So I think we'd have to say that there may be a mix of these conditions that may be involved, and it may vary from patient to patient what is the underlying etiology. Interestingly enough, even though in most of these patients we can identify muscle symptoms, we don't have any good evidence that muscle relaxants work. So let me tell you about our former President Kennedy. When he was a senator in 1955, he consulted Dr. Janet Travell for muscle spasms in his low back. He had a long history of of back pain. He had already had multiple surgeries. And he found that these muscle spasms were radiating into his left leg. They're making walking extremely difficult. He was questioning whether or not he could continue his political career. Dr. Travell injected low doses of procaine into myofascial trigger points in his lumbar muscles. This did in fact give him a lot of relief. She discovered that one of his legs was shorter than the other, and she made heel lifts for all of his left shoes. She identified an underlying mechanical problem that could be one of the triggers, a mechanical problem. Her treatments of Kennedy during the 5 years that preceded his presidency were so successful that he asked her to become personal physician to the president, the first woman and one of the few civilians to ever hold that post. Let's review what the muscle relaxants are. So first we have those that are GABA agonists, baclofen and benzodiazepines. Baclofen working on the GABA B system and benzodiazepines on the GABA A system. Central alpha-2 agonists. Okay, so this medication, tizanidine or Xanaflex, binds to the alpha-2 receptor, activating it. Tricyclic antidepressant-like medications, cyclobenzaprine or Flexeril. Its chemical structure is basically the same as the tricyclic antidepressants. Sedative medications. So a lot of the muscle relaxants are somewhat sedating. Methocarbamol or Robaxin, carisbrolol is Soma, and metazoline is Galaxin. So all three of these medications can be sedating, and these are all pretty common muscle relaxants. So overall, even though we categorize them as I just showed you, we really don't have a lot of information for how they work. Methocarbamol, there's some evidence that it prolongs the refractory period of skeletal muscle. Benzodiazepines potentiate GABA via the GABA A receptors, whereas baclofen binds to GABA B receptors and may inhibit the release of glutamate, a excitatory neurotransmitter, whereas GABA tends to be inhibitory. And tizanidine, which again binds to the alpha-2 receptor, which may inhibit the release of glutamate and decrease excitatory input to the alpha motor neurons. There are some other muscle relaxants. Baclofen goes under the name Leoresol. Besides being oral, it's also available intrathecal, so we will use that in pumps. So a spinal pump like this can be filled with baclofen. This would be implanted under the skin and a catheter would be coming out of this entirely under the skin. This catheter tip would be in the spine of the patient so that baclofen is being pumped into the spinal fluid. Baclofen has to be tapered because withdrawal can be a serious problem. Most muscle relaxants, we have to be very careful in the elderly. Nausea, sedation are side effects. An interesting side effect, particularly with spinal baclofen, is in overdose, the patient can get so relaxed that they're not strong enough to breathe, and that can be fatal. Baclofen, even oral baclofen in times, especially with elderly patients, can cause delirium. Outside of muscle spasm, it has a couple of special uses. One is it is a first-line treatment for trigeminal neuralgia, typically combined with other drugs. And maybe, again, because this is a muscle spasm, hiccups sometimes respond to treatment, chronic hiccups, with baclofen. Tizanidine or Xanaflex, as we mentioned, is an alpha-2 agonist, similar to another drug that you may have heard of called clonidine. It also has to be tapered upon discontinuation. Sedation, low blood pressure, hypotension, dizziness, dry mouth, liver toxicity are all issues that have to be observed or watched for. If tizanidine is given in combination with ibuprofen for the treatment of low back pain, that treatment is more effective than just treating with ibuprofen alone. So it does seem to have some utility in the treatment of low back pain. And in general, low back pain is one of the areas where we see more evidence that muscle relaxants have a role. Cyclobenzaprine, most commonly known as Flexeril. As I mentioned, it's tricyclic in structure. Here's at least some thoughts about how it may work. It may reduce tone and somatic muscle motor activity in the alpha and gamma motor neurons. It does have serotonergic effects like all the tricyclics, so it has to be thought about if other serotonergic drugs are around so that we don't run into toxicity from too much serotonin called serotonin syndrome. I showed you a minute ago that tizanidine added to ibuprofen for low back pain is helpful. Cyclobenzaprine added to ibuprofen for low back pain did not seem to give additional benefit than just ibuprofen alone. Carisoprodol or Soma is a drug that we really don't encourage the use of. It's metabolized to another drug called meprobamate. For those of you with long memories, that was a drug marketed under the name Miltown. It was really the precursor to the benzodiazepines. So it's a benzodiazepine-like drug together with the same problems of dependence and addiction that exist with the benzodiazepines. So of all the all the muscle relaxant drugs, Soma is the one with the greatest risk of abuse. Methocarbamol or Robaxin is the only muscle relaxant that's available IM or IV. Well, almost the only. Dantrolene, which we're really not discussing today, is kind of a different story. It is a old drug, been around a long time, generally well tolerated, but there are side effects that can occur. The same is true for metaxalone, which is scalaxin, and it too has been around a long time, generally well tolerated, but with a bunch of potential side effects. A couple of old muscle relaxants are rarely used nowadays. They were known under the names Paraffin Forte and Norflex. I won't get too much into them. They really are generally not used so much anymore. We did talk about botulinum toxin at the beginning, how it binds at the neuromuscular junction, blocking the release of acetylcholine. But what's interesting is it does cause or block the release of other neurotransmitters at sensory nerve terminals. So we can, to some extent, block the release of glutamate, substance P, and CGRP, calcitonin gene-related peptide. These are all pain neurotransmitters. So botulinum toxin is developing a lot of use in the treatment of pain, even when muscle tension or spasticity is not necessarily part of the problem. And that, in fact, seems to be the case in migraine. So botulinum toxin is now FDA approved for the treatment of migraine. And that does not seem to be the case, or it does not seem to be because it's a muscle relaxant or muscle paralyzer. It doesn't work as well for tension headaches as it does with migraine. So that's really pointing to these other neurotransmitter effects of botulinum toxin. So it's really more appropriate to consider botulinum toxin a muscle paralysis agent rather than a muscle relaxant. It comes from a bacteria that can get inside food. So the classic canned good where the can is puffed up and there's gas inside of that can, that's caused by the Clostridium botulinum bacterium, and that can is likely to be deadly, the food in it. But we can extract the toxin that is made by those bacteria and purify it and give it in tiny doses that can be injected locally. And those can, again, block the neuromuscular junction with an effect developing within a couple of weeks and lasting for at least 3 months. It's not permanent because the motor neurons will actually grow new terminals that are not blocked to activate the muscles. Over time, you can get resistance to the paralytic effects of botulinum because the body will actually develop antibodies to botulinum and neutralize it. You can get rashes. Of course, you can get muscle weakness, so one has to be very careful because too much weakness can cause new or greater mechanical problems. Flu-like symptoms, headaches are not unusual after treatment with botulinum toxin. The most well-known form of this toxin is Botox. It's a type of Botox, botulinum toxin A. There are other A's, and there's also a B. Botulinum toxin B is marketed under the name MyoBlock. So if you dig into some of the treatment guidelines about the use of muscle relaxants, you'll find that the literature is insufficient to evaluate the efficacy of skeletal muscle relaxants in patients with chronic pain. Nevertheless, the American Society of Anesthesiology and the American Society of Regional Anesthesia, the members do agree that there is a role for these muscle relaxants, whereas the consultants were a little bit less sure whether or not these should be used for patients with chronic pain. In the Cochrane database, we do find pretty strong evidence that these are helpful for the treatment of acute low back pain, less evidence for chronic low back pain.